We're coming to the last speaker for today before we announce the poster award winners, and this talk is going to be from Taryn from Georgetown University. We're switching to rhabdomyosarcoma. She will talk about small molecule inhibitors of the PAX3 FOXO1 fusion protein in rhabdomyosarcoma. Welcome.
Hi, everybody. Last talk of the day. Thanks for sticking with me this long. Today I'm going to talk about our lab's efforts to find an inhibitor of PAX3 FOXO1 in rhabdomyosarcoma. So if anybody went to one of the rhabdomyosarcoma posters today, you probably heard that rhabdomyosarcoma is the most common pediatric soft tissue sarcoma. I think you'll see that sentence in just about every introduction. So to give a quick overview, these are some of the primary sites that you can find rhabdomyosarcoma in. And RMS here I'm using as an abbreviation because rhabdomyosarcoma is a bit of a mouthful. And furthermore, you can classify rhabdomyosarcoma into two groups based on histology, alveolar and embryonal. And today I'm going to focus on alveolar, or ARMS. And within ARMS, you can further classify on the basis of fusion status. So I talked about PAX3 FOXO1 in my title, and that gene fusion, which also generates a fusion protein, is present in 60% of ARMS cases, and a related fusion PAX7 FOXO1 is present in about 20% of cases. So total ARMS cases are about 80% fusion positive. And these fusions are associated with a worse prognosis for patients. And it's been shown that they're involved in tumor initiation and maintenance. But interestingly, there aren't any FDA-approved drugs that directly bind to and inhibit these fusion proteins, which is where our lab came into the story. So this is just an overview of the general project. We started out with a pretty large compound library to screen, so about 4,000 compounds. And we used a technique known as surface plasmon resonance, or SPR, where you have a chip, and you can bind a ligand to that chip. In this case, we're binding recombinant PAX3 FOXO1. And then you can flow analytes over the top and see whether or not they bind to your ligand on the chip. And so each of these 4,000 compounds, we were able to flow over the top of the chip. And based on light refraction, you can determine whether or not they bind to your protein of interest. So that funneled us down into about 200 what we call primary hits, which we have further evaluated with a luciferase reporter screen to look and see whether they were capable of inhibiting PAX3 FOXO1 responsive luciferase reporters. That narrowed us down further to our list of secondary hits, which we had about 10 at that point. We went on to do in vivo and in vitro functional testing, and we came out with our top hit, piperacetazine, which is a phenothiazine derivative that was actually FDA approved in the 1960s or 70s for the treatment of schizophrenia. So this is just showing you what it looked like evaluating those hits as far as PAX3 FOXO1 binders. So on the x-axis here, let me see if I can do the pointer. Oh, fancy. On the x-axis here, you can see RH30, which is a fusion-positive cell line. And we're looking for inhibition of this cell line, so 30% or less. But we didn't want to see inhibition of a control cell line. So everything in this gray box up top, those were some of our primary hits for things that were capable of both binding to PAX3 FOXO1 and inhibiting its transcriptional activity. And there you can see the structure of piperacetazine, which is our top hit. And I'm also showing you here some binding data. We performed multiple replicates to get a KD value, which you can see here is 3.8 micromolar for piperacetazine binding to recombinant PAX3 FOXO1. If you're familiar with KD values, the lower you can get it, the better, the tighter the binding. A lot of people look for KD values in the nanomolar range, which is a little lower than this. Put a pin in that, I'll come back to it later. So moving along, we decided to test this, like I said, in vitro and in vivo, and I think these were some of the most encouraging results that we got. This is looking at 3D colony growth in soft agar. And RH30, as I said before, is a fusion-positive cell line. And when you treat with vehicle, you get colony growth. When you treat with the drug that we're studying, piperacetazine, that colony growth goes away. But if you look in a fusion-negative cell line, you have colony growth even with treatment, which indicated to us that the effects that we were seeing were fusion-specific, or at least it suggests that that's the case. So next step was testing in vivo, and I mentioned this to some people who came to my poster earlier. Here's the data. In black, you can see the line for vehicle treatment, and in blue, this is with our drug piperacetazine. You can see there's a bit of a separation of the curves, but our p-value, drum roll, is 0.07, which is not exactly what you want. It doesn't reach statistical significance. Some of the issues behind this experiment were, like I said before, piperacetazine was approved as an antipsychotic. So when we gave the first dose at 30 milligram per kilogram per day in these animals, we saw some extreme lethargy. The animals were not moving at all for 4+ hours. So the veterinary team asked us to drop back the dose. So part of the reason that we think we may not have gotten a statistically significant difference is that we had to drop the dose from what we were originally hoping to do. So we kind of talked before about the fact that drug discovery is an iterative process. So this is where we started out. We went from a big library of 4,000 drugs, and we made it all the way down to a top hit. But our top hit's not perfect. But luckily, you can make derivatives of a top hit, which is what we've done now, partnering with the Wolf Lab at Georgetown. And they've synthesized a bunch of derivatives for us. And now we go all the way back to the start. So these are the derivatives. And now that we have these primary hits, we can do the same thing we did before with an SPR screen to validate that they bind, then go to a luciferase screen to validate that they're inhibitors, and then repeat the in vitro and in vivo functional testing. And this is the point of the process that we're at right now. And we hope to eventually get to a point where we have one or multiple improved inhibitors. What about the inhibitor that I was working with before? We'll come back to that too. We're not completely ignoring piperacetazine. So these are some of the preliminary results, color-coded. This is the repeat luciferase reporter screen. And in this case, I'm showing you all of the drugs that we've tested so far and some that we haven't yet. In red are drugs that performed worse than piperacetazine. In blue, similar. And in green, ones that are better, which are the ones we're focusing on right now moving forward. And also, some further testing of derivatives. We are testing their ability to reduce PAX3-FOXO1 target genes. So if you look at the 72-hour mark here, you can see a reduction in MyoD1, which a couple of people focused on in poster presentations. And we're also testing binding. So one of the derivatives we're working on, EN1238, binds to PAX3-FOXO1, but not to a control protein, esrin. And then going back to piperacetazine, our original hit, like I said, we'd like to improve our drug delivery. One of the techniques that we're looking at right now is using osmotic mini pumps for drug delivery, so we can hopefully get the dose that we were hoping for and not have as many of the side effects. And we're also looking at co-administration of saline while we give the dose so that the mice don't become dehydrated and lose weight. So that is still an active area of investigation for us. And I'm sure a lot of people have questions about the mechanism of action of the drug. And to spoil the story a little bit, we don't know yet. We've tested a few things. If you stopped by my poster, I showed you data about changes in subcellular localization. There are none of PAX3-FOXO1 when we treat. No changes in DNA binding, no changes in PAX3-FOXO1 levels or phosphorylation. So our current hypothesis is protein-protein interactions, so that'll be part of my future work as well. And with that, I'll wrap up so that people can get home. And I'd like to acknowledge a bunch of people, Dr. Urin and Dr. Turetsky, and all of the people who work in their labs, especially, and CCF, thank you so much for having me. And I'm happy to take questions.
Taryn, great work again. Right, I spent a lot of time at your poster peppering you with questions already. Right, obviously, a approach like this is, NCI blue ribbon priority. Right, can we have drugs that target fusion proteins? So, right, super, exciting work and interesting work. I know you're probably not a drug chemist, but for instance, all the derivatives and kind of their structures, does that give any kind of hint of what kind of binding it might be doing, or what kind of we talked about that it probably does not inhibit DNA, binding of that transcription factor. Just any thoughts there, right? Just kind of very interesting set of compounds that you're looking at.
Yeah, I'm definitely not a chemist, but I can tell you some of the things that I do know. So the derivatives that we're working with, the moieties on the molecule that have been changed are this right here, which don't ask me to name what it is. Well, I'll leave that to the chemists. And this over here. And that phenothiazine moiety, which is those 3 rings at the bottom, that has mostly been unchanged, I believe, in the derivatives that we've worked with. And we've seen pretty good binding for almost all of the derivatives that we've tested so far with SPR. So I think the verdict is still out on what part of the molecule is required to bind PAX3-FOXO1.
Maybe I'll ask a question. I saw promethazine. Was that on the list as better, under better? Because that could be something you could potentially more easily test.
Yeah, so they're on that list of commercially available derivatives. Promethazine was one of the ones. When these drugs were first developed in the 60s and 70s, I think there were a lot of pharma companies that were making as many different versions of them that they could. And I'm sure there are still some on random shelves out there that we don't have access to. But that was one of them that was successful, and we've been able to purchase it and start testing it in vitro.
And when I talked with Jeff earlier, is that the drug that you were thinking you might have to give as a continuous infusion, or is that something that?
Yeah. Okay.
Great.
Thank you so much, everyone.
Thank you.